Hello and welcome to today's internal medicine webinar. My name's Lydia Morgan and I'm Senior Commercial Manager here at Virtual Veterinary Specialists. I'll be introducing our speaker for today, Dr Jessica Adamany, in the final of her four-part lunchtime internal medicine webinar series. The topic she'll be covering today is urinary tract infections in the dog and cat. If you missed last week's webinar on proteinuria, you can catch up on our YouTube channel. You can also find links to the recordings of all of our previous webinars on our website and all of our social media feeds. VVS have a team of friendly and knowledgeable veterinary specialists who can support you with advice calls, written reports, radiology requests, or with our Halo service, our live guided specialist consultations. These include specialist live guided cardiology workups and live guided abdominal ultrasound with internal medicine review. Our internal medicine advice calls and written reports can be accessed by any veterinary team. There's no need to register or subscribe. Do you find yourself wasting time playing telephone tennis with referral centres for vague support with a case? Well, with VVS, you can receive a comprehensive call at a time convenient to you, offering significantly more insight and case support, tailored to your key concerns and questions. For those of you attending London Vet Show this year, do come and say hello. We're so pleased to be joined by Jessica Adamany on the Friday of the show, as well as Professor Rob Folt on the Thursday and Dr Nuala Summerfield on both Thursday and Friday. Find out how you can collaborate on cases with our specialists to feel more empowered and supported. With VVS, you can also develop your clinical skills through experiential learning, speed up clinical decision making, and retain practice revenue. You can find us at stand P45. We'll have delicious coffee and cake waiting for you. So it's now my pleasure to introduce Dr. Jessica Adamany, European Specialist in Small Animal Internal Medicine. In 2013, Jessica undertook a residency in internal medicine at Pride, becoming European diplomat in internal medicine in 2017. She remained at Pride as senior medicine clinician, co-director of the rotating internship program, and resident supervisor. Jessica is passionate about sharing her knowledge and teaching. We're so lucky to have her on the VVS team, bringing her compassion and care alongside her huge enthusiasm for veterinary medicine. If you have any questions as we go through the webinar, please add them to the chat box. We'll host a short question and answer session at the end and cover your questions then. Thank you again for joining us. It's without further ado, I'll hand over to Jessica for today's webinar.
Perfect. Thank you very much, Lydia. So as Lydia said, today I will speak about subclinical bacteriuria and urinary tract infections. So the objectives of this lecture would be to review the 2019 ISCAID guidelines. So there are numerous guidelines from ISCAID on multiple diseases, but also antibiotic therapy for urinary tract infections, respiratory infections, things like that. They should be getting new guidelines in 2023, 2024, so please look out for those. We'll speak about appropriate collection and handling of urine samples. I want you guys to be able to recognize subclinical bacteriuria and feel confident about not treating it or monitoring it if needed. I'd like for you to understand the differences in diagnosis, treatment, and follow-up for sporadic cystitis as well as relapse infections so that we know how to appropriately treat them and manage them. And then a big goal of all of these recommendations and differences in the guidelines over the years is really to improve antibiotic stewardship, and extremely important for human medicine and human patients, but as well as one of the first steps is in veterinary medicine. So what is antibiotic stewardship? It's really the effort to improve, to measure and improve antibiotic prescription by physicians, and then what's being taken by the patients, okay? So we really need to improve who we're giving the antibiotics to, what we are treating, what antibiotic we're giving, and for how long, okay? We know that genital urinary tract infections are the third most common cause for antibiotic use in dogs. And therefore, it's a really good place. So it's about 12% of oral prescriptions. And it's a very good place to really get started on improving our antibiotic prescription and therefore improving stewardship. There was a recent paper in JSAP, so Journal of Small Practice in 2021, and it looked at regional use of antibiotics in dogs and cats with urinary tract infections. And, it's very important for us to not only know what antibiotics usually work on certain bacteria, but it's also good to know what resistant patterns we have in our hospital, but also regionally in the country. And so this paper was very interesting, and it showed what antibiotics we're often using, but also showed that there is becoming significant resistance to ampicillin, amoxicillin, and even at times amoxicillin with clavulanic acid, with relation mainly to E. coli, but that's one of the most common bacteria that we find. So we need to really be careful about what antibiotics we're using, for how long, making sure that we truly need to use it, and then paying attention to resistance patterns. So in 2018, this group did a study looking at animals, so 150 dogs with signs of urinary tract disease, and how first opinion vets diagnose these cases and how they manage them. So it was 150 dogs with signs of urinary tract disease. 81% of them had sediment exam, and only 56% of them had bacterial culture. So not that many. 51% of these dogs, so half of them, had a UTI confirmed on culture. So they had the appropriate clinical signs and sediment, and on culture, bacteria was found and grown. But 85% of patients were treated. Okay, so more patients than needed were treated. And of those, only 62% were treated appropriately. So mainly saw that 36% of cases were overprescribed. And this is most likely, and what they've noticed in the study is most likely because we start empirically treating patients, and then we wait for the culture. But then when the vets were getting the culture results back, if it was negative, we were not stopping the antibiotics, we were continuing them. So a lot of these patients were overprescribed, and they also were giving them for too long, okay? Whereas 2%, so smaller amount, were underprescribed. What they also saw was about 57% of cases used second-line antibiotics, despite having that sensitivity panel. So it's extremely important that we are making sure that we're doing the correct tests. So more of these patients should have had a bacterial culture before starting antibiotics. And paying attention to that culture and sensitivity results. Okay, so if the results come back is negative for growth, then we stop the antibiotics. Or if it is susceptible to a lower tier antibiotic, we use that over a second line antibiotic. So the ISCA guidelines, you should be able to have access to them. You can find them in Vet Journal. So there was a version in 2011. The more recent one was 2019. The main chair was Scott Weiss, and he was just at our ECVIM, so European Internal Medicine Conference, giving quite a few lectures, and he said that there was a new one coming out in 2023-24. So please have a look at that when you hear it's come out. These guidelines, or at least the 2019 guideline, focused on new terminology and differentiated what we call subclinical bacteria and urinary tract infections, so a bacterial cystitis. And be aware that, subclinical bacteria, we call it asymptomatic bacteria in women. It's very common. It's greater than 20% of women, I think over 80 have it. But we call them asymptomatic because we can really tell that they don't have clinical signs, where I guess in our dogs and cats, we don't think that they have clinical signs. So we call them subclinical bacteria. In these guidelines, they provide very detailed recommendations for the diagnosis and appropriate treatment of upper and lower urinary tract infections, and also kind of what should we do with bacteria, okay, subclinical bacteria. However, what we need to remember is that these are just general guidelines. They are a foundation to build on, and even the members of this specialist committee, at times they were having to also make up their own recommendations, okay? I guess make up is a hard word it's also one that Scott Weiss said, at times we had to make up a duration to use antibiotics, but it's being made up based on some papers that we have, but also what we see in human medicine, okay? So these guidelines are acceptable for the majority of cases, but not all. And so it's still very important for you as a veterinarian to use your clinical judgment in making decisions on a case-by-case basis to decide, does this patient need antibiotics or not? And if you're really not sure, maybe we try a short course and see what the response is, okay? And it's also important that we, like I mentioned previously, pay attention to the resistant patterns within our hospital or regionally. And really our goals with this are to decrease improper antimicrobial use, because that can lead to resistance, increased cost to the patient or to the client, and adverse effects on the patient. The more we use antibiotics, at least in people, it's been shown that you're changing the flora, especially the vaginal flora or the genital flora. And therefore, these patients actually, when you're trying to treat an infection, are predisposed to getting more infections, or they're predisposed to getting resistant infections that maybe at some point we can't treat. So although at times we assume that it's benign, antibiotic therapy is not completely benign. So let's look through the classifications of urinary tract infections and bacterial cystitis, and then we'll move on to subclinical bacteria. So these are definitions, again, taken from the ISCAID guidelines. So urinary tract infection or bacterial cystitis, it's the adherence, multiplication, and persistence of infectious agents within the urogenital system, okay? And it is based on culture. And it causes an inflammatory response, and these patients have clinical signs, okay? So it's the big thing here is that you have a positive culture and they have clinical signs. So there's a few different types. We speak about sporadic bacterial cystitis. So again, it is a sporadic infection. It's a rare infection, and they have clinical signs, okay? We call it sporadic when it is less than 3 episodes in 12 months. Previously, and also what I was taught in vet school, and I think in also the 2011 guidelines, the sporadic bacterial cystitis was also known as a uncomplicated. It should be simple uncomplicated. And the reason why the guidelines have changed or the classification has changed is because we used to say they were complicated or uncomplicated based on if there was an underlying cause. And in these patients, we don't think there's an underlying cause, but also the question is just because they're complicated, does that really mean that we need to treat them differently, or do they really need to be treated longer? And there's no proof to say that just because there's an underlying reason for why they, let's say, are predisposed to infections, that they deserve a longer treatment, and that hasn't been shown. So again, sporadic bacterial cystitis is now the term that we use for urinary tract infections that have occurred less than 3 episodes in 12 months. And often it's usually in patients that have not had antibiotic therapy before. And then we have recurrent bacterial cystitis. So this is greater than 3 episodes in 12 months or greater than 2 in 6 months. And there's 3 different types of recurrent bacterial cystitis. So we have reinfection, and that is where the patient gets infected with a different organism. Okay, so they get multiple urinary tract infections, but it is a different organism. So it's important to also to be aware, though, that it still can be an E. coli, but it can be an E. coli that is genetically a little bit different. Okay, so just because it says E. coli and has the same resistance pattern doesn't always mean it's the exact same organism. You can do genotyping to figure that out, but it's probably beyond where we often go. Okay. Often reinfections are due to an alteration in the host defenses. So some reason why the patient is just predisposed to getting more infections, okay? You can also have a relapse urinary tract infection, and that is when they get infected with the same organism that was previously diagnosed. It is often caused by reservoirs of bacteria that are sitting there in the kidneys, or often in tissue. So not just sitting out in the urine, but in the tissue. So in the kidneys, the prostate, maybe a stone, the vagina, the submucosa, okay? And so antibiotics, what they'll do is it's easy to kill the bacteria that are floating around in the urine, but they're not very good at killing the bacteria that are in the tissue, okay? And occasionally these infections can be very, very difficult to clear, okay? And they're the ones that you see where you start treating them, the infection goes away, and then it equally then shortly after comes back. And then there's persistent infections, and these are ones that we're just unable to clear. So the first kind of thing we need to look at is if they're on antibiotics, are we using the right antibiotic? Is the owner giving to the patient at the frequency and at the dose that we recommended? But also, is this patient immunocompromised for a reason? Is there a bacterial resistance? So again, looking at that culture and sensitivity, maybe having to reculture. Are they unable to reach sufficient urinary concentration? So is the drug not being absorbed very well because it's gastrointestinal disease? Is there hepatic or renal disease that's affecting metabolism, excretion? Okay. And then again, like I said previously, thinking of owner compliance. And then we have this category that we're speaking about, you're hearing about very often right now. It's subclinical bacteriuria. So it's the presence of bacteria in the urine determined by a positive urine culture with or without inflammation, okay, on the cytology, but it is absence of clinical signs. So you have growth of bacteria, but this patient has no clinical signs, okay? And again, like I said, we call it subclinical because we really can't call it asymptomatic because the patient can't tell us. So the prevalence of urinary tract infection, so in their lifetime, it affects about 14% of dogs, definitely more females than males, and about 1 to 9. 9 sounds rather high, but based on papers I could find, they said 1 to 9% of cats. Subclinical bacteriuria, I mean, it ranges, there's huge ranges, and really it can be from 2 up to 74% of cases, and it really depends on the population that you're looking at in dogs and in cats. I definitely see it more often in dogs than in cats, but it's equally something that I see frequently. And then of course we see true urinary tract infections, so bacterial cystitis and subclinical bacteriuria, more often in the presence of comorbidities. But that doesn't mean that we have to treat them differently, okay? Or just because a patient with subclinical bacteriuria has a comorbidity that we should be treating them. So the pathogenesis of urinary tract infections, or I guess bacteriuria in general, so it's multifactorial. You got to look at the virulence of the organism. So how do they adhere? Do they have fimbriae? Do they have specific toxins that they use? Do they make a biofilm, sequester iron? And so looking at kind of specific things to that organism, but then also looking at the host. So as a host, we have natural defenses that are natural and or acquired ones. So looking at, are we urinating normally? So of course we see the patients that have a true urethral dyssynergia or have spinal cord disease and they can't completely void their bladder. And so their micturition is not normal, okay? And we see that they're more often having subclinical bacteriuria or urinary tract infections. What about the anatomic structures? Is there a stone? Do they have ectopic ureters? Looking at the antimicrobial properties of the urine, mucosal defenses, and the immunity of the patient. So it is multifactorial in terms of how we get these urinary tract infections. It's more often a bacteria that's coming from the skin and the gastrointestinal tract. Okay, so those are the two main origins. And so when local and systemic defenses are inadequate, the pathogenic bacteria can migrate up the distal urethra to the bladder. They adhere to the epithelium of the bladder. They colonize and invade. Neutrophils then enter and try to remove as much bacteria as they can, but some of them can evade the immune system, enter epithelial cells, and basically they get resistance to neutrophils. They can make a biofilm, okay? And then these bacteria then cause toxins, proteases that cause cell damage. As I mentioned previously, a lot of these patients have comorbidities, and this is a long list of, well, in dogs and in cats, reported comorbidities, and also signalment things that increase the risk of bacteriuria, so subclinical or true urinary tract infections. So we see them more often in females. We see them as they get older in patients with chronic kidney disease or endocrinopathies, gastrointestinal disease, if they have stones, if they have neoplasia of the urinary tract. So there's lots of different reasons. And this, the multiple papers will speak to you about, these are the comorbidities, or these are the cases that we often see subclinical bacteria or urinary tract infections. But just something that's interesting to know. It probably doesn't change what we do. So the pathogens, I wanted to go through the pathogens because it can be very helpful to know them, to therefore know what antibiotics are best. But also when you get that culture back, paying attention to what kind of growth do I have? Is it a pure growth? About 75 to 94% of dogs and cats, they will have a single agent. and also knowing what's the most common or more common bacteria that we see in dogs versus cats. And therefore, is the culture result that we have, is it reliable or not? Okay, so we know that bacterial infections are most frequent. Viral are very rare. We will have fungal infections. In one paper, it was about 0.4% of dogs had Candida infections. Okay, and protozoa is very rare. Again, more often are they single agents. This table is taken out of that 2021 Journal of Small Practice paper, looking at local resistance, and it also looked at what type of bacteria you were seeing. In the majority of papers do correspond, they're similar to these results. So in dogs, we see definitely more gram-negative bacteria than gram-positive, and E. coli followed by Proteus are the most common. In cats, most papers will say gram-positive bacteria are found as commonly as gram-negative. In this paper, you can see that it was a little bit less. Again, E. coli is most common, followed by Enterococcus and Staph in cats. So clinical signs of urinary tract infections. So we have stranguria, we can have plaqueuria, hematuria, periuria, so they're urinating around the house. They might just be over-grooming, licking their genitals. But also in some patients that might have prostatitis or pyelonephritis, you might see that they also have pain on abdominal palpation or palpation of these organs. Okay, they might also have pyrexia. So there are, of course, an array of clinical signs that we can see, but these are the most common ones. And it's very important in your history, when the history is being taken, to really ask some big questions to try to differentiate what's going on. So, it can help us make sure the patient's actually having signs of lower urinary tract disease, and also assess for other complicating or factors or comorbidities. So does the patient actually have plaqueuria, or how many times do patients come in and they keep telling you that, they're walking down the street and they're constantly lifting their leg to go to the toilet, and they think it's plaqueuria, but no, this patient is just marking. And does the patient have periuria from increased thirst and urination? So are they urinating around the house because they're urinating big volumes, or are they actually asking to go outside all the time, or having accidents in the house, but they're very small volumes? And has there been a history of incontinence? So is this patient walking around and has been dribbling urine its entire life, and therefore maybe it has ectopic ureters, or maybe it has a hooded vulva? Looking at the urine stream, okay, so you want to make sure they have a good urine stream, that they're fully emptying their bladder. So these are questions that can help us really have an idea of what's going on. And is it a storage disorder? Is it a voiding disorder? It's not just having accidents in the house. We need more information than that to really be able to focus our diagnostic investigations. What about bacteriuria and neurologic signs? So it's something that we hear doctors speak about very frequently in humans. So it's been shown that humans with bacteriuria that can be clinical or asymptomatic have been associated with confusion, delirium, being tired, walking abnormally, and worsening of pre-existing neurologic disorders. We see it often in, elderly women and men, I guess, that have dementia, okay, or Alzheimer's, and they have an acute deterioration of their neurologic disease, and often doctors are the first thing they're checking is a urine sample. And so there are reports showing that there's significant improvement when they start treating them with antibiotics and supportive care. So it does show causation between the deterioration in the neurologic status of the patient and treating the bacteria, even if asymptomatic, which is interesting. So there was a paper, I don't know the year, it's probably a few years ago, also in Journal of Small Practice, where they looked at bacteriuria and encephalopathy in dogs and cats. So looking mainly at forebrain, maybe brainstem disease, and actually showed that when known extracranial and structural causes were excluded, so all other causes to explain an encephalopathy, a lot of these group of patients also had subclinical bacteriuria. And when they treated them for their bacteriuria and gave them supportive care, these patients improved, sorry. So maybe this is an area where, if you have a patient presenting with forebrain disease, okay, and all other causes have been ruled out, maybe it's worthwhile looking for this patient to see if they have bacteriuria and providing antibiotic therapy, okay? But again, it's not one where you would look for this initially. It seems to be rare at the moment, at least. So it could be a possible indication for urinalysis and culture if we can't find another cause to explain this clinical signs. But it was a very interesting paper to show that it can be similar to what we see in people. So diagnosis of bacteria. So the way to truly diagnose it, the gold standard is to have a urine culture and growth on the urine culture. Now, in dogs that have a sporadic cystitis, you don't always have to culture them the first time, okay? And if they've not had antibiotics before, it's their first urinary tract infection. We do know empirical treatment that we can use, so it's okay to use it, okay? But again, if we're getting to having them more frequently, it's worthwhile definitely culturing them. In cats, I mean, I would say always culture. We know that, urinary tract infections as a cause of lower urinary tract disease in cats is extremely rare. Diseases like FIC are much more common. So definitely have a look at the bladder, make sure there's no stones. Definitely culture. It's very likely it's going to be negative. So it's something where we shouldn't just treat them empirically with antibiotics. Culture method. So we all know that the best way to do it, to collect a sample sterilely with cystocentesis. However, sometimes it's not possible. Sometimes we will need to get a voided sample or a urinary catheter sample, depending on if it's contraindicated. So if the bladder, if it looks like there's a tumor, things like that. It's ideal to process it immediately. There's tables like the one below. This one's in dogs, looking at the amount of growth that we should have based on how we're collecting the urine. Pay attention to what kind of bacteria you're growing. So as we mentioned previously, the different pathogens that are more common in dogs and in cats. So, making sure that you are getting a pathogen that's to be expected and, knowing if it's pure growth. I mean, if you have like 3 different types of growth, maybe that's not a reliable sample. What about handling and transport of these urinary samples? So there are a few papers. In my opinion, we need more to know what's best. What we do know is that, yes, it's best if you can culture it immediately. So after you take it, being able to culture it or plate it in-house is ideal. If you can't and you need to send it to an external lab, it's best to refrigerate it in a sterile tube. Okay, so it's been shown in one paper or in 2 papers that the colony forming units is similar between when you plate it immediately versus having it in the fridge for 24 hours. If it's greater than 24 hours, the papers show variable results. One show that maybe up to 48 hours in the fridge is okay. Some others say that if you're going to keep it at room temperature or need to transport it for over 24 hours, it should go in a transport medium. What I would say is really do your best at having the sample and having it processed or in the fridge and then processed within 24 hours. If you can't, just need to know the limitations of having the sample in the fridge for longer, and it can increase or decrease bacterial growth. And maybe you'll have to resample at some point, but it would be interesting to have a paper that shows, there are times at my practice where a sample could be collected on Friday, and not be processed for at least 2 days. So it'd be interesting to have more studies that look at, okay, I've had it in the fridge for 2 days, I've had it in the fridge for 3 days, and how does that compare to when it's done immediately? But as of right now, I would say if you can do it immediately, that is best. If not, in the fridge for when it's less than 24 hours, and then have it plated. And then, of course, we should send it away for culture and susceptibility testing. So we look for aerobic cultures and susceptibility testing, and usually get bacterial growth in 18 to 24 hours. There's different susceptibility testing based on where you send it, and you could always ask for its disk diffusion versus dilution. Okay. So what if your culture is negative and your patient does have clinical signs and maybe has pyuria and there's bacteria? So either it's not a true bacterial cystitis, you have a tumor, a urolith, other types of or another cause of inflammation like FIC that's explaining the clinical signs and the inflammation. Maybe that patient had an antibiotic before you sampled, okay, and therefore the culture is now negative. You might have a deep-seated infection. So there are times where, like I mentioned previously, with recurrent infections where you can treat the bacteria that are in the bladder, but you're not getting deep penetration into the tissue, and therefore the patient still has clinical signs, but when you culture the urine, it's clear. You can have extreme characteristics of the urine. So then after sampling, the bacteria might die. Poor sample handling, as we just discussed. And then you might have a slow-growing pathogen, so Mycoplasma, Corynebacterium. So it might be something that you want to speak to the pathologist about, and saying that you thought you saw bacteria on the slides. Could it be a slow-growing pathogen, and how can you test for that? Now, what about USG, dipstick, and urine sediment? So with the urine-specific gravity, don't routinely culture samples with a low USG, especially if the sediment is inactive. If the sediment is active and the patient is clinical, then definitely do a culture. But we shouldn't be having these reflexive cultures where just because the urine concentration is low, we're going to culture it to see if there's bacteria. It doesn't matter if the patient isn't clinical. The dipstick, the leukocytes, and the nitrates, they're not reliable. And then sediment. Sediment is helpful in giving us some more information in that patient that's clinical. So what we do know from quite a few studies is that looking at a wet mount is just not sufficient. So the slides do need to be stained. A lot of the studies are looking at right stain or gram stain. We use a Uri stain, which also, there's not as many studies in dogs and cats as there is in humans, but it's also, all these stains increase the sensitivity and specificity dramatically. So don't be looking at wet stains. Really take the time to centrifuge, to get the pellet, and then stain the slide. But also we have these automated technology now. So there's a SediVue. I think there's also a vet scan that's available. So there is a paper in 191 cats of feline urine samples. And, this study was just looking at what the sensitivity and specificity was with this machine. And really, when the sample was said bacteria are definitely present, the sensitivity and sensitivity was 100% and the specificity was 96%. And when they said that there was no bacteria, they were also correct. So the machine can be very reliable when it says that they are present versus not present. But when it said suspected bacteria, this is really when you need to have a look at the sediment, okay? And of these 95 that had suspected bacteria, only 14 were positive. So when you included these cases, the specificity decreased quite a bit, so many false positives. But when it says suspected, it's definitely worthwhile you taking the time again to check the machine, okay? We will be better than a machine. So always make sure that if it's suspected, you then have a look yourself. And when are other investigations required? So it's rare for sporadic urinary tract infections, okay? Often you treat and then we see what happens, and if they keep coming back, then yes, it's worth looking. At that time, we could be considering laboratory work, checking the kidneys, checking organ function. You can do abdominal radiographs, abdominal ultrasound, contrast studies. We might need to take a sample from the kidney, so a pilocentesis, check the prostate, maybe do a prostatic wash or cytology. There's been more papers and also another lecture at the European Congress looking at, when do we need to scope these patients for when they have recurrent urinary tract infections compared to the other tests that we can do with imaging. And in women, really scoping them only provided pertinent information in less than 5% of cats. And in one of our papers, so in JVIM 2022, it was really useful in only 10% of cases. And these are cases where maybe you find ectopic ureters, or maybe you found a stone in the urethra, but it's going to be not very common. So they don't often need to be referred for scoping, okay? And then what about bladder biopsies? So if you have a patient with, lower urinary tract disease and you've ruled out all other causes and you think that it's coming from a sterile cystitis, yes, you want biopsies for histopathology. But what about culturing these biopsies? And before people used to culture them quite a bit. It seems to be done less and less, and it's probably because you need a subset of patients that you are taking biopsies on. I mean, you want a patient that's been off antibiotics and that has a negative urine culture at the time before going in and taking biopsies, because the only way to interpret if there is a deep sea infection is that you have a normal urine and bacteria present in the bladder wall. So it's not something that we do very often. I find that if I suspect that the patient has a deep-seated infection, I just treat them for longer and with an antibiotic that penetrates deeper, or the bladder tissue. But there will be rare cases where we need bladder biopsies. So it's just to say that a lot of the investigations you guys can do in general practice. So in vitro susceptibility testing, remember, it is in vitro, so it predicts the sensitivity of specific antibiotics. It can determine and predict based on what method you use, the MIC, and they compare that to specific breakpoints. So the lab has specific breakpoints that they use that are for serum and urine, so for tissue or urine, to determine, based on that MIC, is this bacteria susceptible, intermediate, or resistant to the antibiotic. With UTIs that are intermediate, okay, that implies they likely can be efficacious if the antibiotic is concentrated in the bladder. So just because it says intermediate, don't just write it off. Of course, if you can, use a susceptible antibiotic, but do know that if you have a drug that does concentrate in the bladder, then an intermediate result still might be an option. So what antibiotics should we choose, especially when you get a huge susceptibility panel and it says a lot of them can be useful? So we want to use the weakest and safest antibiotic that's susceptible. These include non-combination drugs, so using amoxicillin versus amoxicillin with clavulanic acid, and using earlier generations, so first generation cephalosporin versus, I should say, a third generation cephalosporin, okay? So that means potentially staying away from things like Convinia, which are a third generation cephalosporin. We also want to use, we know that we want to use safer drugs, and these safer drugs have a wide margin of tolerance and a low risk to the patient. And then remembering that really fluoroquinolones and third and fourth generation cephalosporins, we should reserve those for bacteria that are resistant or ones that we believe are in the tissue, okay? So now I have a diagnosis of bacteria. What do we do? So what about subclinical bacteria? Do we treat it? Do we not? So at the moment, the veterinary literature is maybe not scarce, maybe it's medium. We are seeing more and more papers on this subject and more papers on healthy dogs and cats. And when we followed them over, I think it was in dogs, it was 3 months, in cats, it was quite a few years. Did that increase their morbidity and mortality, which it did not? And then now specifically looking at specific disease entities, and if it increases their morbidity and mortality, to ignore a subclinical bacteria that's present. What we know is in humans, we know the bladder is not a sterile site, and treatment is not advised in numerous conditions. So you can have patients that are immunocompromised, have spinal disorders, have endocrinopathies, so diabetes, and these patients are not being screened for urinary tract infections when they are asymptomatic. Exceptions at the moment include when they're undergoing an invasive urinary procedure, or there's mucosal bleeding during the procedure. And then in pregnant women, which is, I mentioned, plus or minus, so they used to treat women. Nowadays, although the risk for a pyelonephritis is higher in pregnant women, the morbidity behind it is low. So in certain countries, they are not always treating them or not always screening for them. What we need to remember is that treatment will only eliminate the bacteria in the short term, and they will recolonize. Okay, so it isn't a sterile site. And there likely is an underlying reason for why this patient is getting subclinical bacteria. So will recolonize. And is it going to recolonize with a more resistant bacteria? It's very possible. And it's also been shown that there is no decrease in morbidity for these patients. This was a paper that was compiled by Dr. Weiss, so the main chair for the ISCAID guidelines, and he presented it at the ECVIM Congress. And, these are some of the papers that we have in showing what was the prevalence of subclinical bacteriuria in these cases. And you can see that it can be extremely high. And I would say clinically speaking, we probably see it also being even higher than what's reported in some of these studies. And really, despite all of this, we don't see these patients presenting all the time with urosepsis or pyelonephritis. So just another indication that look how common it is, and we're really not seeing complications due to subclinical bacteria. So again, in dogs and cats, we have seen that really in the healthy patient, at least, we don't see an increase in morbidity and mortality, and we haven't seen it also in diabetics, Cushing's, IVDD, and so in lots of other patients so far, we haven't seen that treatment of a subclinical bacteria improves outcome. It's not the case, okay? And so therefore, it's recommended right now that we do not randomly screen these patients for bacteria. So you don't want to have your patient that's diabetic, that's well controlled, and that you see once or twice a year, always collecting a urine sample, because you know that these patients can get urinary tract infections and have a high predisposition for subclinical bacteria. Why are you going to treat it that one time of year? You're just making a more resistant bacteria, okay? So don't randomly screen your patients. Test them if they're clinical, okay? Treat the lab result. Sorry, do not treat the lab result, okay? Just because the culture is positive, again, doesn't mean they need to be treated. So you're not treating the owners, okay? The owners, yes, the dog has or cat has signs of lower urinary tract disease. That doesn't mean that this patient always needs an antibiotic. And that's not treat our conscience. I think sometimes we feel that we just need to do something. But what we need to remember is that what we need to do is do no harm, and that just giving antibiotics when it's not been proven that they need them and they're not clinical for it can result in harm, okay? However, again, we still need more, in my opinion, we still need more studies to look at specific disease states, okay? So right now we have these recommendations, but yes, these recommendations might change once we have more studies on specific disease states and when we don't treat them, okay? When we don't treat the subclinical bacteria. And again, really, you got to, as a clinician, we need to use our judgment, pay attention to the patient's clinical signs, their exam, lab results, and discussing with the owners. Also got to make sure that these owners are very good at observing their animals. Possible exceptions for culturing and treating. So if you suspect the patient has a pyelonephritis, of course, if they have signs of lower urinary tract disease, we will. If they're having surgery or endoscopy and there's expected mucosal bleeding, some specialists will put them on antibiotics before and a few days afterwards. If you think there's urosepsis, if when you image them, there's encrusting cystitis or emphysematous cystitis, or if we suspect a urease producing bacteria. So if we see a stone and let's say the pH is high and we suspect that it's a urease producing bacteria, we often will try to treat them with antibiotics and even check them even if they're not clinical, okay? So these are other diseases that might require more thought. So again, I mentioned previously undiagnosed central nervous system disease, in cases of chronic kidney disease. So a lot of these cats will have subclinical bacteria. Yes, maybe we worry about a pyelonephritis, but also a lot of these patients, they will continue to have a subclinical bacteria and not develop a pyelonephritis. There are certain specialists that will try a one-off treatment of the infection that they find and see if the patient improves or if the bacteria doesn't come back. Often it does come back. So it's really speaking to the owners more and getting them to observe the patient just to make sure they don't start to develop signs such as a pyelonephritis. It's also knowing, is it it's a spinal disease dog? So the dog on the right, they can't show you that they're clinical, but it also is paying attention to how the patient is. Are they lethargic? Do they have a temperature? What does the urine look like, smell like? Has there been a significant change? So it's paying attention to the whole picture, especially in these patients where you can't really know if they're clinical or not, okay? And again, the last one, an uncontrolled diabetic or a DKA patient, I don't often, if I haven't found another underlying cause to explain why they become uncontrolled, yes, I'll check the urine, but it's not one of the common causes of an uncontrolled diabetic. And a lot of times they will have bacteriuria, okay? So yes, it's something that we can look at afterwards, lower down the differential list. Same thing with undiagnosed central nervous system disease. But it's not something that I'm constantly screening for, okay? And again, this is if you see echoic urine on ultrasound, it doesn't mean that we need to sample. If the patient's not clinical, it's not something that we need to look into. And then follow-up, of course, if we're not treating it, there is no follow-up, so none. Sure, ask these owners, especially with cases of chronic kidney disease, to watch the animal closely to see if they develop signs of a urinary tract infection or signs that could be consistent with a prostatitis or pyelonephritis, okay? But what if we have a patient that we're not quite sure they have signs of cystitis, but we're not sure if they have cystitis and, let's say, subclinical bacteria. So you have a patient with FIC, but there also is bacteria. And, is it just because the patient has FIC and subclinical bacteria, or is this bacteria causing a problem? Or such as on the right, a patient that has a TCC in their bladder, are the clinical signs due to the fact they have the tumor, or is it because they have bacteria? So in these cases, it could be worth trying a short trial of antibiotics, so 3 to 5 days, and assessing response. And if you see an improvement, great. There probably was a component to those bacteria causing a bacterial cystitis in addition to the FIC or the tumor. If you don't see a response, it's likely subclinical bacteria. So really got to focus on the other cause that could be causing the signs of cystitis. Now, what about sporadic cystitis? So this is something where, we can use empirical therapy in dogs, okay? So we can try empirical antibiotics. However, we also can try non-steroidal therapy. So in people, they're also at times trying a day or two of non-steroidal therapy to see if we can get rid of the pain, if the patient can clear the infection, or at least giving anti-inflammatories while you wait for a culture result, okay? So most common antibiotic that's empirical choices should really be amoxicillin. You could also try a cephalexin or a TMS. But the best thing to do would be to be guided by culture and sensitivity and then the local resistance. And a plot for convenia. So again, this is a antibiotic that is a 3rd generation cephalosporin. It can be good for E. coli that's in the bladder, but not in the tissue. And it lasts for 14 days. So we're using a higher generation drug than we really should be using. And based on information that we have in humans and based on very few papers at the moment, it's recommended that we be treating, our patients only for 3 to 5 days, whereas convenia can last for up to 14. So it is really a drug where we're using too much. And so I'd recommend against it if you can treat the patient in other ways, okay? Now, this duration of 3 to 5 days, the reason why I have question marks after it is, again, this is something that they said they kind of made up or extrapolated from humans. We have a few papers in dogs where we looked at shortened antibiotic courses and response to therapy. However, these studies looked at comparing one drug, such as TMS, with a very short duration to a longer duration of, let's say, cephalexin, okay? So although there was no difference in response, the drugs were different. So it's difficult to say, well, do they just need 3 days of any antibiotic, or do they need 3 days of this specific antibiotic? So hopefully in the future, we'll come out with more studies saying comparing 3 days of cephalexin to 14 days of cephalexin, 5 days of TMS with 10 days of TMS. So we're looking hopefully in that, and then we'll get more data on to truly how long these patients should be treated. So follow-up, again, what we're looking for is not microbial cure. We want clinical cure. So that's what's most important. So resolution of clinical signs, okay? If there is not resolution of clinical signs, if there is resolution of clinical signs, there's no need to change the antibiotic. If the clinical signs don't resolve, you need to look at your culture and sensitivity again, okay? Or, what's the compliance of the owner? Is the dog absorbing the drug cat appropriately? Are there any other clinical signs? Okay, but again, it's clinical cure that we're looking for, not microbial cure. So we do not need to be rechecking this urinalysis and culturing it again. For recurrent bacterial cystitis, for reinfections, it's the same plan as sporadic cystitis. We treat them the same, but make sure you try to identify and manage any predisposing factors. For relapse and persistent infections, you want to ensure that antibiotics are reaching appropriate concentrations, and then looking to see if, do we think we have a deep-seated infection or other predisposing causes. The antibiotics should be based on culture and sensitivity always. And if we think it's a deep-seated infection or one that's in the kidneys, we should be using ones that reach appropriate tissue concentrations, okay? So using fluoroquinolones, cephalosporins, TMS would be advised. As I mentioned in the last slide, for reinfection, we only want to be treating them about 3 to 5 days, okay? For relapse and persistent infections, right now it's recommended to only treat them for 7 to 14 days. Previously, I think it was about 28, but right now, extrapolating from human medicine and based on clinical experience, we're seeing that you can see a significant improvement in 7 to 14 days. So follow-up really depends on what clinician you speak to. And the consensus is not recommended when you, well, as previously for short courses. When longer courses are recommended, you can perform them, so mid-treatment and at the end, so a few days after completing the treatment, but they're not always, it's not recommended, okay? It's reasonable, but you don't have to do it, okay? And again, it's because we're looking at the clinical signs of the patient. So just because you have still a positive culture, the clinical signs are gone, it's not going to change what you do, okay? So again, goal is clinical cure, not microbial cure. Now, preventative therapies might be something that you guys are questioning. I have two. The guidelines don't really recommend any of these preventative therapies or other drugs that can be helpful in changing the bacterial flora. So we speak about cranberry extract, which I think more and more the data in women are showing that it can be helpful to prevent these urinary tract infections, especially with E. coli. It's been mixed studies in dogs. It's true, it doesn't cause any harm, so it could be worth trying, especially in E. coli infection. But they've also looked into probiotics, which also have not been shown to be very useful. So unfortunately, we don't have many other therapies right now that can be helpful. And just another, I didn't go through, pyelonephritis, prostatitis, but just because I find this interesting, I wanted to briefly speak about pyelonephritis, and again, speak about convenia and how to make sure the lab is using the correct breakpoints when doing your culture and susceptibility testing. So again, when a patient presents and you think they have a pyelonephritis, we want to start empirical therapy because they're very unwell, and that is while a culture is pending. You want to pick a drug that penetrates tissue, okay? But again, convenia shouldn't be used. What we know right now is that it's not great at penetrating tissue and reaching appropriate concentrations, especially for an E. coli, okay, in tissue. So it's not something that we should be using. If you start empirical therapy and the clinical signs are still present and the culture and susceptibility say that it's resistant, you should change the antibiotic. And then make sure that when you're sending, if you're sending urine to the lab, make sure that they're aware that you are checking for pylon or you suspect pyelonephritis, because they will use different breakpoints for the antibiotics and be able to tell you if it's susceptible, intermediate, or resistant, okay? They will use the tissue breakpoints rather than urine ones, okay? Because we want those bacteria to reach appropriate concentrations in the tissue. And interesting enough, again, this is the treatment duration has decreased. Right now, it's recommended, at least in the current guidelines, at 14 days. And rechecking them. So 1 to 2 weeks after antibiotics, full recheck, physical exam, blood work, and culture. But again, as long as there's resolution of the azotemia and the clinical signs, if there still is a positive culture, although it sounds a little bit scary, you won't do anything about it besides watch that patient closely. So key points, pyuria, bacteria, they don't equal bacterial cystitis, okay? We need to have a patient that has a positive urine culture with clinical signs. Let's stop screening dogs and cats for bacteria and focus on the patients that truly have clinical signs. We can use empirical antibiotics. They're acceptable in dogs. with suspected sporadic cystitis. Make sure that we're using first-line antibiotics and using them for appropriate durations to help antibiotic stewardship and try to prevent or decrease the risk of resistant urinary tract infections. Let's pay attention to the culture and sensitivity. Again, picking the first-line antibiotic, and also helping with paying attention to local or hospital resistance patterns. And remember that it's clinical cure, not microbial cure. Thank you very much.
Thank you so much, Jess. That was really interesting. If anyone has any questions, please feel free to pop them in the chat box, and we can answer any questions you might have. And I've had a question while people add. Do you ever use like the supplements for cat bladders with at all? Like
You when they have FIC.
Okay.
Is that what you're talking about? When
Well,
they have...
like the cysties and the
yeah, so a lot of those things, the support behind those drugs, it's not very strong. So usually I don't. Diet and things like that have been shown, increasing water, environmental enrichment, those have been shown to be beneficial. But the support behind, or the evidence behind a lot of these supplements, it's not strong at the moment, so no.
Fantastic. And when you're waiting for the culture and sensitivity, you normally just keep patients on suitable anti-inflammatories. Would you ever, if they're really struggling, start an antibiotic course, or where possible avoid?
Personally, so yes, I would often start them on a non-steroidal if we can while we're waiting. If the patient is very unwell, and let's say I see bacteria and white cells and they're clinical on a smear, and it's at the first, so it's sporadic, then yes, I will try. And then of course, yes, if the patient is extremely unwell, I think sometimes, again, we need to use our clinical judgment. So yes, these are guidelines, but not every patient's going to fit those guidelines. So I have used empirical therapy in a dog that I suspect now has a recurrent infection while we're waiting for the culture.
Fantastic. Well, you're a quiet bunch today. Oh, we've just got one question.
Yep.
I have a dog with over 3 E. coli urinary tract infections over the last 6 months. She's clinical symptoms and painful bladder. She's on low dose steroids for IBD, PLE, and mild Cushing symptoms. Would you ideally come off the steroids fully? Her scan is clear.
Is that she is painful? Is that correct?
Painful bladder, yes.
Yeah. And she has IBD
and PLE.
Okay.
And
I mean, I think that if you can
symptoms.
taper them off the steroids, that would be ideal. I guess we would need to speak about how long you're also treating this patient for, especially for an E. coli infection that could be deep-seated. So it's probably one that we need to see how long you're treating this patient for, and if you're treating them appropriately. But yes, this is a perfect example of where there's predisposing factors and complicating factors where they're likely going to continue getting these infections. So maybe in this one, it'd be cool to try the cranberry, and also making sure that we're using the correct duration and correct drug for the E. coli. I bet you this dog has a deep-seated infection, so you probably should be using like a fluoroquinolone and for a longer duration.
Right. That sounds like an interesting case, Annette. Do get in touch if we can help you
in
any way with it. Yeah, exactly. So as we mentioned at the start, if you ever do want to discuss any of your internal medicine cases, all of the VVS internal medicine team and our other specialties are very, very happy to talk through your cases. You submit your history, so your lab results, your PDF history, and any relevant information in advance, so you're fully up to date, know what's going on in the case just before you speak with the vets, which is really helpful, so you can make sure it's tailored and suitable to what would be appropriate for that case. So we're always really happy to organise advice calls. You can visit our website and go onto the book now to book in and submit some history. But otherwise, there's no more questions through. So I think we've covered everything. We really hope to see you at London Vet Show next week. Looking forward to seeing everyone. Do come by our stand P45. And thank you, Jess, for another great
My
webinar.
pleasure. Thank you, everyone.
Thank you, everyone. Bye.